full disclosure, a lot of the stuff that you're going to be hearing today is going to be great for the residents studying for the core. A lot of it's also going to be helpful for the attendings who are already out in practice. So just by a show of hands, how many residents are there in the audience? A few, and most of them are attendings. So out of all of my lectures, I'm sorry to start this way, but this is the most painful lecture for if you're already out in practice. But for a resident, this is the most important lecture. And the last lecture is the second most important lecture for the residents as well. So for the attendings, if you want to listen to this online, you have that option. So quality control in nuclear medicine. These are my two disclosures. I'm a consultant for in vitro and Blue Earth Diagnostics. They have nothing to do with my presentations. I have 3 objectives for quality control. Number 1, we're going to discuss how QC issues can occur in nuclear medicine studies. Number 2, we're going to understand what the NRC, the Nuclear Regulatory Commission, defines as a medical event. This is when you have to notify the NRC. And lastly, we're going to discuss quality assurance issues for gamma cameras and those calibers and what we should be doing every day, every week, quarterly, and annually. All right, so we're going to start as a case-based course here. So when you look at this image, this is from a bone scan. You have the anterior and you have the posterior view. And there's something a little bit off on this, and hopefully you can see one view looks a little bit worse than the other. And then we repeated it, and now both views look great. So on this view, which view looks worse? And then which view did not change very much? So I think it's easier to say like the posterior view looks pretty similar on both and looks pretty high quality. But if you look at the anterior view, it looks very blurry. Much more blurry than it does on the posterior view, and that improves dramatically on the repeated image. So what is the cause of that? Does anyone want to just shout it out? I mean, but this is something that you're going to have to know. This is usually when the detector is too far away. When there's only an issue with one camera, it's on the anterior view, patient's claustrophobic, and the technologist, the patient does not want the detector close to them. So why is that important? Well, if you look very carefully, there's a small focus here in the sternum, a little bit better on the repeat image, which we said was suspicious, and that turned out to be an isolated met to the mid-sternum, which progressed dramatically in 7 months. 12 months later, it's still confined to the sternum. Unfortunately, at 18 months, it progressed significantly with diffuse osseous metastatic disease. And just look at the CT. Here's the initial study. This was not seen. There's a very tiny sclerotic lesion. 7 months later, you have an expansile lytic lesion. So the diagnosis on this case was that the detector was too far away from the patient, and this patient did have osseous metastatic disease, completely changing the management. So I did not have this at the time when I was studying for the core, or at my time, I was, it was an oral exam.
Okay. All right, so the objectives for this session, we're going to talk about the airway first, and we're going to talk about lungs, mediastinum, which will cover some of the things that were discussed previously, but a little different. And finally, don't forget the bones. That's really important. Okay, and again, I will point out some key learning points. So in the airway, we're going to talk about tracheomalacia, croup, subglottic pathology, which is not croup, and the retropharyngeal area. So normal airway, we need to know what normal is. The trachea is the longest and narrowest in inspiration. In expiration, it buckles away from the side of the aortic arch. Our previous speaker talked about how on the one x-ray, you saw the trachea moved a little bit to the left, and it looks like there was an indentation on the right side of the trachea, because that was a sign of a right arch. So the same follows in children or adolescents. So we're going to talk about all ages here, outside of the neonate. When the trachea buckles, it buckles away from the side of the aortic arch. So during an expiratory film, if you see it buckling to the left, the child has a right aortic arch, okay? And so that should help clue you in, especially if they're coming in with stridor. Subglottic area has normal shoulders, and we'll talk about what that means. Here's an example of the inspiration and how the trachea looks the longest and narrowest, straight here, okay? Yes, this patient has big adenoids and tonsils, but let's ignore that for now. And now here's the example of the airway in expiration and how it's buckling, all right? And when it buckles during expiration, look how big and fat the retropharyngeal soft tissues are. It's the same patient, they're normal, but during expiration, they will look and mimic disease. So keep that in mind. If you're not sure and it looks like the x-ray is not taken properly, repeat it before you call there being some pathology. All right, so let's talk first about tracheomalacia. Well, the airway in infants and children is very flaccid and cartilaginous, so it's very easy to collapse, especially if there is some type of, it could be idiopathic, or if there was some underlying mass or vascular ring. You can see why compression of the trachea will result in abnormal breathing, but will result in a collapse, okay? Most tracheomalacia is primary, it's idiopathic, and it's medically managed, and they will outgrow it. So what does it look like on imaging? It could be either focal or diffuse, and we talk about the airway disappearing. Sometimes what we do is we will do fluoroscopic exams still for these, and we'll do dynamic airway studies where I watch the patients crying, where when they're crying, they're doing inspiration, expiration very rapidly. Or we'll ask them to breathe in and out, and I watch inspiration and expiration. And this is what you will see. You'll see collapse of the trachea.
I'm going to close out the non-breast and non-interpretive skills, non-interpretive skills section of the course with the last GI case review here. So let's get into it. Okay, so we're going old school, probably something nobody's doing anymore. I certainly do not have a plethora of experience in this, but we're going to look at it anyway. So small bowel follow through with our paddle compression device. So we splay out those loops and we see things nicely. So this patient had weight loss. So what are we observing here? So I'll show you a few different views. And here's a full frontal projection after the study. So what did you see here? And what is your differential? Weight loss. Any ideas? Which is often seen in? Right. So exactly. So fold reversal, often seen in celiac disease. Excellent. So the normal fold pattern, which we'll see in a minute, we should have more folds more proximally in the jejunum, less folds in the ileum, right? So when we have fold reversal, that's a sign of celiac disease. Excellent. And it's considered also sort of nodular. I think that's sort of tough to see sometimes. You know, I don't know how nodular that really is, but that is what it's considered. So so here's your differential when you encounter these types of things, but in this case with the fold reversal, it was celiac disease. So let's look at another case. So here was a small bowel follow through in a patient who was known to have Crohn's. So this patient had Crohn's, right? And so let's talk about normal bowel features here just on MRI so we have a sense. So again, more folds with increased thickness in the jejunum, so much so that it's very often overcalled on just ER studies when the proximal jejunum is underdistended, right? People say, oh, it's thickened, there's like jejunitis, right? Like it's not, look for stranding around it. We typically do not see that on just normal kind of people in the ER who don't have some pre-existing bowel problem. So remember, lots of folds in the jejunum, they're thicker. When it's decompressed, it looks abnormal, but it's not. Unless there's some stranding or some obstruction or something, don't call it abnormal. Ileum will have fewer folds that are thinner or smoother, or both. And I don't remember these numbers, how many folds per centimeter or whatever, but there they are for you. So normal wall thickness on a distended portion of bowel, typically about 2 millimeters or less.